Okay, in the interest of time, so we don't keep you too late, I'm gonna start the program. Please eat, go out, get your dessert. The chocolate cake looks beautiful. Please eat all of it before I go out and try to get any of it. I'm gonna just have some thank you notes for the drug reps that came in. We're really appreciative of your presence, and your support. So I'm just gonna mention the company's name. I'm not gonna mention the individual reps here names because just in interest of time. So AbbVie, Allergan, Chiesi, Cystic Fibrosis Foundation is here, and we're very excited right there. Electromed, Foundation Care, Gilead, Kroger, Specialty, Novartis, Perry, Respirtech, and Vertex. And really, from the number of sponsors coming in to support this function, it is really very, very impressive. So thank you very much. Now, every year we've been doing this function, and every year we announce it and we mention it to the people in pediatrics and in adult staff and the faculty. And it's really been very impressive, the number of people sign up and come to the function because they really truly want to be with the families and talk with them and share experience. So I'm going to mention the staff. We divided them into pediatric, inpatient, outpatient, and adults, and then I'll go through them. If I forget anybody or if I butcher anybody's name, I'm from Egypt originally, so so inpatient pediatrics, that's the 12 East floor. That's my floor that I love and adore. Lori Barnett, Liz Barron, Judy Belinda, Diane Brown, Nancy King, Kate Thorrington, and Sharon Wilson. So thank you very much for coming. From the outpatient, I really did not threaten anybody that they have to come. They just came by themselves. So Amy Filbren, our associate director, is here. Toby, I think Toby Lewis is coming. Oh, she's right there. Ines Thomas, our endocrinologist, pediatric endocrinologist. Lauren Kastner, our fellow, should be here as well. Fatma Nimashwala is our second fellow. Jennifer Butcher is coming in a little late. Lisa Kinzig, and that's very interesting. Lisa is not even work in the clinical area. She works in the research area, and she came. I didn't know that she was going to be here, so that's very nice that she came. Courtney Bauer, one of our secretaries. Sandy Boma, one of our dietitian, and Courtney is our other dietitian. Cassie Enox is with the baby over there, and this is the newest addition to our division, and we're going to sign up the baby to be working with us in the center too. Jordan Stifler, and she is the next pregnant one. Trisha Vess, Julie is here as well. Herman and Sharon Ryder from RT, Kelsey from RT, Cindy Jones from RT. Bree, Vicky, Erica, all of these are RTs, and a lot of them are new to our program, and we're very excited to have them with us today. Chris Tapley is our physical therapist, and Kate Tallis, and they've been wonderful. They really are getting the people in the clinic, the kids working, so that's really good. I think Kate is going to make me exercise more too. Dawn Cruz is our research manager. She is doing a great job, and she's here looking for people and trying to get more drums for the research. And Megan Podas is our the newest research addition that we're very excited about. In the adult side, Dr. Simon just made it here, so which is very exciting because I was volunteering Dr. Sisson to give your talk. You don't come. Katie Hall and Ronnie Downer, both of them are the coordinators for the adult program. Shishing Jia, which is a new faculty member. She did her fellowship here. She's been very dynamic in getting involved with CF research and CF care. Zara Sanduk, she's an adult endocrinologist that's also now dragged into diabetes and CF. Vikas Sood, he's a nurse practitioner, and he's been very dynamic in helping us with studies and with the STOP2 study and other things. Ian Ong, Emily Hauser, Kristen Keith, Gumati Kanfadi, Kristen Kidd, and then another Gumati, no, they wrote it twice. And then Linda Fitzgerald. So all of these are really faculty and staff that are here to support the function. At the Family Advisory Board, we're very excited about the Family Advisory Board. They really make us work hard. So we meet every, 2 months or something like that. And every time I tell my husband I'm gonna be late because there is a Family Advisory Board. He's like, again? Wasn't it just last month? So, and we're very excited about all the projects that they are involved with and they are working on as well. So we have Chris Barth and Sarah Barth here. And yeah, if you want to stand up because you guys are, doing a lot of work. Erin Boylett, she could not make it today, but she always is. Wendy Carmack is here. Brandy Finner and Josh Finner, and I love Brandy. She always volunteers her husband for everything. She's like, oh yeah, he'll do it. I mean, without asking. Rihanna Geyser, Dawn Neiman, and Sharon Tissue are all here, so we're very excited to have them. There are announcements that I need to mention before I forget. So make sure to pick up a handout, including our Family Advisory Board newsletter. That's something new that they wanted to do, so they did it, and it looks really beautiful. We took 3 of them to the Cystic Fibrosis North American meeting, and they came up with several ideas. One of them was the newsletter, so they did it, and it looks really good. Also, there is a flyer for our meet and greet. They also wanted to have a fall meeting, not only just the spring meeting. So the flyer about it is outside, and it's really a different format, and I think you're really going to enjoy coming to that. It's not going to be fall this year. It's going to be actually in May because I caught myself. It used to be in the fall, but now we're moving it to May because before the summer comes in. Please also remember to take evaluation form. We always look for the evaluation and what topics you wanted and how can we make this better. So please take the evaluation and tell us what you think of the function and how to make it better, and it's on your table. And then the local chapter, the local CF chapter, will have Caitlin Ulrich saying a few words, and she is new also in her position. So, right?
We reached Ann Arbor.
Ann Arbor, yeah. Yeah. Okay. Well, excellent.
Thank you. Hi. Thanks, everybody. So quickly, I wanted to introduce somebody who we're really lucky to have in from our Bethesda office. Actually, this is Jackie, and she is joining us from the Compass program.
Hi. I'm so happy to be here with all of you guys tonight. I'm with the Compass team. Our services are free to the CF community, and we can help you in 4 main areas. If you're needing help evaluating new insurance coverage plans, or if you're experiencing any insurance-related issues. Also, if you go to clinic and you're prescribed new medications, or you need help getting connected to the different copay programs that are available, our team can explain all of those programs and help lower your out-of-pocket costs. Also, for our legal bucket that we call, if you're needing help learning more about Social Security benefits, or if you're wanting to learn more about your legal resources that are available to you, we can connect you with resources for that. And lastly, we have our other bucket. So everything that falls outside of those other areas, our team has connected the community to resources for help with scholarships, programs that exist to help with transportation costs, food insecurity, things like that. So if you're needing any assistance in any of those areas, or if you'd like to learn more, please come see me after the presentations. I also have materials that you can take home with you. So thank you.
Thanks, Jackie. So As they said, my name is Caitlin. I'm very fortunate to be a staff member here at our Michigan chapter office of the Cystic Fibrosis Foundation. Just wanted to take a few minutes of your time to talk about some things that we have going on at the foundation. So if you work with the CFF at all, you hear the phrase adding tomorrows a lot. And that's because that's our mission. More tomorrows for each and every person who's living with cystic fibrosis. But along the way, we want to make the todays as good as they can. We don't just want quantity of life, we want quality of life as well. So that's why we're focusing a lot on programs like Compass. We know that cystic fibrosis and getting access to care can be very difficult and complicated. And so that's why we have a program like Compass that helps you navigate through those issues. Another great program that we have that's pretty new is called CF Peer Connect. And this program actually came from listening directly to our community, hearing from them. It's hard to live with this disease without somebody next to me who knows exactly what I'm going through, somebody to talk to who's, had the same decisions to make about getting a lung transplant or working full time while caring for themselves with CF. Another awesome program that has come out of feedback from our community are BreatheCons, and these are these unique online events where people from all over the country can interact, which we know is something that our community really likes to have. We even just had one that's a family con, so any family members and caregivers to someone with CF could log on and talk to other people around the country who are going through the same things that they are. Another area that we're focusing our efforts on is advocacy. And that's because it's a part of our mission to ensure access to high quality specialized care, which means we have to look to the community to raise our voices and make sure the CF voice is heard anytime there's a policy change that could affect the CF community. Another phrase that we say a lot at the CF Foundation is until it's done. And that's because it really encompasses so much of who we are and what we do at the CF Foundation. Until it's done means funding research into infections that patients with CF get. It means treating all the symptoms, but also constantly pushing forwards towards that one-time cure. It means learning everything we can about lung transplantation and CF-related diabetes. We have families who've been with us by our side for 30 years, fundraising, coming out to events, fighting and raising their voices, who because of their genetic default are not going to have a modulator therapy. And that's why we really have to push forward towards that one-time cure. And that's why we do great strides. In 16 cities across the state of Michigan, we're very fortunate to have an amazing care center. Here at U of M, we have teams from both adults and peds who come join us Saturday, May 12th. They'll be at Washington Community College. So we would love it if you would come out and just come chat with us, come ask a question. We'd love to introduce ourselves and just get to know you better. So thank you very much. Have a great night.
Okay, so as usual, every year I usually present the data from our center, but I also not only going to present the data, it's really each segment of it, what are we doing about it to get it better? And we, of course, need help from everybody, all the parents, and of course, the teenagers, my favorite group of patients that don't listen usually. So I chose, last year my theme was better, was actually about football, which I love. But this year, we went to the eclipse in Oregon when it happened in the US. So it was a very exciting time for us. We've been going to eclipses. This is our third one. So, and every time there is more excitement about it. So I think the group with us. So I'm going to be just giving you a little bit of background about quality improvement work that we've been very involved in our center. Recent, and then also the summary of the registry data, because you want to see that, and then current projects that everybody in the pediatric side is involved with, and adult, I think they're having some things as well. So we know that adherence is a problem. We're asking the kids to do things every single day and to do too many of them, and there is a lot of time limitation to that. So we do understand that. However, there are a lot of studies done to see what is the rate of adherence in children. And overall, it's reported in pulmonary medications about 48%, and that was a big study that including over 3,000 people. From our study, we've done a lot of work on adherence here as well, and we've looked at through questionnaires of what is the adherence rate for patients. And it was 49%, for inhaled hypertonic saline and 59 for Pulmozyme, which is, to me, I would think everything should be done 100%, but this is reality here. Adherence to enzymes and to even ivacaftor, which is like the drug that everybody's really excited about, is not that optimal either. And we know that poor adherence is associated with kids that are not doing that well. They come in and I'm looking at their lung function. I'm asking them how they're doing, and we're doing everything. And then when you look at the lung function, it's like, why is it low? Then they would like, yeah, we don't do it all the time. It's really good to encourage your kids to tell us what they're doing, because we can help them that way rather than tell us what they think we want to hear. So medication adherence, we have evaluated that again with several studies that we've done for evaluation of adherence. So one of them, this one, we did it over 5-year period. So we got a hold of refill data from 3 big pharmacies that we think most of the kids are using, and we did it for all the patient center that we have. And it was interesting. We looked at the hypertonic saline, we looked at the Pulmozyme, the tobramycin inhalation solution, and enzymes and vitamins, thinking that maybe the inhaled medication would be more adhering than the oral, or maybe the other way around. So it was kind of interesting that what we found. And we looked at the nutritional status, and we looked at the lung function. And there were better adherence in inhaled medication than oral. You would think oral is just a pill, you pop it in your mouth and you're done, but no, that actually, I think it's in the kids' mind, my interpretation, could be totally wrong, that they really want to focus on what they think is more important, and the nebulizer and the inhaler they thought was maybe more important. So looking at that, we wanted to design a study to see, can we help out? And I think I ran that in more details last year. And that we had a questionnaire. We asked the patient, what would make you do your treatment better? What would remind you to do the medication better? And we had in the questionnaire, apps on the phone, somebody calling to remind you, we have several things. And one of them, doing pulmonary function testing at home more regularly, because when you come to clinic and you see your lung function, that help you get better for the next month or 2, and then you kind of forget. So we designed this study, and this device in the middle is really a small thing, and that you hold it in your hand. It actually can be a reminder as well, and you can do the lung function, you can do it up to 1 time a day. We were asking for only once a week. And this is the results from there, and then you can see that at baseline for Pulmozyme, we did it over a year period, so they have the machine with them for a year, and we were calling them once a week to see, are they having any problem with the machine? It wasn't to tell them, are you doing your medicine? Because we didn't want to interfere, but just by calling them, that is a reminder in itself. So there was a difference between before, like at the baseline, and then at the end of the study. You can see that Dornase alpha got better from baseline. The inhaled hypertonic got better, but the vitamins didn't really get that much better. So another project that we're very involved in, and it's really working, I think, well, is the transitioning patient to the adult side. So this is very important as the kids get older. This slide is very telling that now we have more adults than pediatrics, and actually the adult program in Michigan is bigger than the pediatric now. They have, I think, 310 or 15 patients, and we have about 270. So it is catching up. They're getting older and living longer, which is awesome. That's great. We're very excited about it. But that means really we need to make sure the handover from pediatric to adult is done correctly. So in the University of Michigan, we've been doing transition in 1980 started. That's way before my time. And it was really done by the coordinator at the time, which was a social worker. And he was able to get the adult and the peds center director, well, the adult and peds pulmonologist, the peds center director, and the adult pulmonologist to work together. And they were, invested enough to start the transition program. Since then, In 1990, we evaluated, because any program you do, you need to evaluate to make sure you're on the right track. And we did some changes after that. And then again in 2010, we evaluated and did some changes after that. All that was fine, but do we have like objective way of telling my adult colleagues that the patients are mature enough, know their medication, or they don't, like, assess their level of knowledge and their level of adherence in a more cohesive way? And that took us to the CFRD's program. It's a national program. Actually, now it's going to be international because Canada wanted to use it. I was in Italy recently. They really wanted to use it, and I presented there several times about that. So CFRD's is the responsibility, independence, self-care, and education. So you mainly work with the patient to try to see what their level of knowledge. It's a short questions, and then it gives you the answers, as you're doing it, if you're doing it electronically, and then move you towards the education material that you would need to see, to learn if you have done a mistake or something like that. So that's been really very thoughtful program that's been adopted by most centers in the country here. And like I said, Canada recently asked for it, and then other countries as well. So what we usually do is that we used to start at 16. Now Julie, our champion, is not only tracking down all the 16-year-olds and above. We transition around 18 to 21. So she tracks them down. She gives them modules, remind them to do their work. If they don't do it at home, she hunt them down in the clinic and make them do it. And it's really important to encourage the kids to do it, because that helped them. And also there is part of it that helped transfer the responsibility from the parents to the children, to the kids. That way the kids can call us instead of mom calling, can call for refill, can call for change appointment. So when they're ready to go to the adult side, mom is not doing everything for them, or dad. So now the program actually went down to 10 years of age, and it's, of course, depending on the level. There is material for 10 to 15, and then from 16 to 21, there are different level, like third grade level for the younger and fifth for the older. And it's mainly, we usually send a letter to let the parents know or give it to them in the clinic. We try to show them the modules, as we call it. It's short, so each one is 1 or 2 pages, and it's mainly reading through the questions and answering. Like I said, you can do it at home or you can do it here. And the beauty of it is that, in clinic, there are lots of people go in and out. I mean, we have the respiratory therapist, the dietitian, the nurse, the social worker, the PT, me, who else is there? Psychology is there. And between people going in and out, they can, answer 1 or 2 questions. So that way it's not adding to their time. And it's really important to have the patient buy in and the parents buy in. And I don't think there is anybody that refused to do it. It just needs a lot of persuasion, but they end up doing it. Also, they cannot say no to Julie. We take advantage of that. So that's a program that we've been really advanced in it, and we've been doing it for the last 2-3 years, and it's been paying off quite a bit. Now going to our center date. So, the little babies, the less than 24 months of age, are always our problem. It's the small number. It's only 24 babies, and if one of them lose weight, drag the data down. So that's, but we look at it and we're taking it seriously, that our data is actually lower than the national average in that part. We're at 53.9% weight for length versus 65.9. So we are working on this, and I'm going to get into it. And the way we work on these things is that not only that we start working on the high-risk group or the group that are not doing that well, but we do it for everybody. So that way, the ones that are doing really well continue to do well. Because the last thing we need is the ones that's doing well try to start dragging down. So we do it for everybody. So this is just to show you. This is for the 2 to 19-year-old. It's a little better. We're a little above the national average, but still, I really would like to be more in the left side of the curve, more. And this is for 20 and older. So it's similar data, and So So what did we do about it? I mean, okay, we looked at the data. We look at it every year. We have the team together, and we put our head together and say, okay, what's going on? First, the nutritional data are seen by our dietitian, who take it very seriously and personally and start working on it. So what we did is that, what are the factors that's causing this poor food intake? Why are the babies and the patients are not eating enough? They gain the weight, they get exacerbation, they lose a lot of weight. So exacerbation is a factor. Acute or chronic sinusitis, they're not smelling their food and they're not feeling that well, so that again affected. A lot of them have abdominal pain, and recently we had a new member of our team, a pediatric gastroenterologist, and she comes to clinic often, and the amount of constipation in our patients is amazing. So it's really high. So she's been really working with us on that. Nasal polyps and avoidance of high-calorie food. That some kids or some parents even tell me they need to eat healthy. They need to eat vegetables. I'm like, okay, I eat vegetables. It doesn't have calories. Don't do that. So, put some, dressing on it. Do some things with it. But some parents really wanted very healthy food, meaning very, lean food, and then we get in trouble. But some kids don't like it too. The more you tell them, the more they don't want to do it. In addition to CF, some kids have depression. It's a chronic disease. It's known for chronic disease have more, increased rate of depression, anxiety, stress, being sad, especially if they come to the hospital. Some of them have eating disorder, and that's why our psychologist is a very important part of our team. We also have a psychiatrist that work with us very closely. Inflammatory bowel disease, and we just have a patient with Crohn's disease, so you have to always think about that kind of thing, and that's why the GI doctor with us and getting some people involved, and I know the adult side are very lucky to have involvement from the adult colleague as well. And medication side effects, especially the ADHD kids, they would get treated and then they would lose their appetite and they're losing weight, and we wonder what's going on, and then we let the pediatrician know that order to switch it around or do something because it does reduce their appetite. And then some people don't have the means, they don't have enough resources. So that's another thing that we need to keep in mind. So we started to have ideas to improve our BMI, and we divided all the patients into people, what's their BMI, where are they with the BMI, and we listed the patients that are less than 50% or less, and we started working together. One thing we did recently is that the dietitians looked at all the patients and looked at their enzyme dosing per kilo, and you might have gotten calls from her saying, okay, yes, they're doing well, but we really want to maximize the enzyme dosing. And a lot of the parents agreed, and we did it, and the kids start gaining better weight, because that's one of the things that the research showed, is that if you get higher dose of enzyme, then you're absorbing better. So we've done that for all the patients. It doesn't matter what their BMI is. So that was with the focus on the lower BMI. Enzyme dosing was adjusted. I have a mom that not only let us adjust it per kilo per meal, but the intake of fat and intake of protein, and I know who I'm talking about. And she's going the extra step for us. We've been really working hard in getting high calorie and giving ideas of what is high calorie but supplement. And we worked with the state, with the Children's Special Health and Medicaid, to make sure to allow us to give patients supplement if their BMI is 75% or lower. And actually, I'm able to get it for higher than 75% if they've been on it. So we just communicate with the state, and they've been very supportive of that. Appetite stimulants, we do a lot of appetite stimulants in our center. There's actually a list in the clinic highlighted with number 1, 2, 3, 4, so you can start the process from the beginning. And the beauty of it too is that not only the physician do that, but the dietitian and the nurses are on it as well, and that's really what remind the physician to do, because it's a busy clinic. If one of the appetite stimulants not working well, We can increase the dose, we can change to another one. So we have the list we go to. And then we talk about G-tube. And it's really not the end of the world. I mean, it's a way to help improve the nutrition. So we've been really talking about putting gastrostomy tube in patients to help with the weight gain. And it's all a process that we work with depending on the comfort of the family. There are some families that I talked about G-tube for 2 years before they agree, and some, all I say is just mention it and they're jumping on it. So it depends on the stress level at home as well. And then we follow them quarterly or sooner. So Courtney and Sandy are really good in keeping up with the families and calling them. And families, a lot of, when you look at the charts for patients, you find that a lot of calls are from Courtney and from Sandy because they're working on the nutrition. And then there is also a pre-clinic huddle, which all of the staff meet together and talk about the patients and label the patient like, this is high risk, we need to focus on the diet, we need to focus on the lung function. So it's really labeled, it's not in a bad way, about what to do with the patient and what they need. And we divided them into 4 groups. That's been ongoing for years now, that, the BMI less than 10%, and we really focus more on the less than 10 and the less than 25 with the high calorie diet. We get them supplement, and kids don't like supplements sometimes, so we give the choices to choose from. And once they like one, we usually order it for them. But again, the G-tube is very important for us, and the appetite stimulant. Some of them have problems psychologically, and that's where Jennifer Butcher comes in, our psychologist, and she would point out to, like, there is a problem, something like that. We're involved right now in a study called Design study, which is really working. It's 4 centers. It's led by Cincinnati, and we're one of the 4 centers. And it's mainly to help parents use an online system to be able to, have calories information and see how can we improve weight gain with that. And some parents were part of the design material that was done. And then we also don't forget the ones that are doing well. We don't want to forget them. So the ones that are doing well, we need to make sure they're continuing to do well. So going to the FEV1, or the pulmonary function testing, and this is our data. We're still above national average, but just a little bit above national average. We want it to be at 100%, but you can see from the curve that every line is a center. See how close we are? I mean, between the best center with 110% to close to the end of the thing, which is about 90%. So there is not a lot of wiggle room. Every center is working really hard to improve their pulmonary function, which is wonderful for our patient. This is for 13 to 17-year-old, and this is for 6 to 17 now together. And then this is for the adult side. So again, it's important to look at it. You can see that I really want to be in one of the best centers in the FEV1, and each, there is no one center that is best in all categories. So just keep that in mind as well. So what are we doing with the FEV1? Because we saw that, and I didn't show that, but over the last few years, the data has been going a little bit down. So we used to be a lot higher than that. So we wanted to jump on it before we were below national average. So we created a project, and actually we're doing it in collaboration with the Cystic Fibrosis Foundation. A lot of the focus of the foundation is quality improvement, and we're involved actually in 2 projects with them right now. So this is one of them. And the beauty of that project is to improve FEV1 is that everybody in the center is involved. All the nurses, all the secretaries even are involved. The social worker, the dietitian, psychologist, everybody is involved. Of course, the physicians are involved. And we get credit for it. We'll have a center site visit in the fall, and we usually let the site visitor know that we are doing projects like that. So it's been really very, very exciting to have the whole team working on it. It's a lot of work. A lot of it is done by the coordinator and by the nurse, by respiratory therapist, which are very, very important. They entering the data on each patient every time they come in, which is really very helpful. So during the clinic, we look at the FEV1. We're focusing on patients that are less than 80%, and we have a list of them, and we're following them. But again, everything applies to every patient. And we look at their medication. Are they on bronchodilator, albuterol or Xopenex? Are they, if they have symptoms, if they're less than 80%, are they on Pulmozyme? Are they on hypertonic? And if they're not, we can discuss and have them on it. And the thing is that you have the pre-clinic huddle, so the nurses are looking at the list of the medication, so an alert with the physician, and there is a post-clinic meeting. So if the physician forgets to order something, then we remind them afterwards. So it's really a comprehensive center approach to everything. So if I forget something, I'm reminded. If somebody grows Pseudomonas for the first time, there are so many eyes looking at the chart that I don't think it can be missed, even if we try. So it's really very exciting to see that. In clinic, if the lung function is dropping, we usually repeat the lung function, give them bronchodilator, repeat it to see if there is any asthma component or not. So if there isn't, then is it an infection going on? So there is an algorithm for every step of the way to see how can we be ahead of the game, not wait for them to get sick, but be ahead of it. The spirometry, when they leave the hospital, in the hospital we do it twice a week. We used to not do that, but now we do it twice a week, and that guides the length of time they're gonna be in the hospital. And also when they go home, we bring them back in a month to see them within a month to see how they're doing, repeat the lung function, see how they're, so it's more like a closer eye on everybody. And actually we started to see results. I mean, we started to see improvement in these patients. So we're very excited about that. The most recent project that we are doing right now, and the research team is doing it. So the research team was not part of the FEV1 QI project. So I created one for them. So now they should be happy. So this project is mainly looking at all the research that we do, the multi-center research, and how can we do things better, starting from the time we get the protocol from the sponsor or the foundation. How does we get approval, how fast we get approval, how well we're doing the recruitment, how well we're telling patients about and families about the studies. So we're addressing it from every aspect. We hired Megan specifically to be in clinic, in adult and peds, to tell parents about it and to tell patients, because a lot of the patient, when you ask them and families, they would say, oh, nobody ever approached us. So it's good to have her there. She approached everybody, whether you're a candidate for a study or not, so you just know what's going on. And she has a list of the studies that's going on for your information. So that project we're very excited about. It's called Equip CR. And we're having Dr. Gia with us as well from the adult side, which is a luxury. We have not had that before. So now that we have participation from the adult side as well. And it was really, we had the meeting yesterday, the external visitors came, and it was wonderful. I mean, and all the leadership in the institution met with them. I approached everybody, the leader in the IRB, the leader in the contract office, the directors of the divisions. Nobody's told me no. I mean, everybody said, this is the best time for me, put me in. And it's really exciting to see that they wanted to help. It just explained to them the urgency of doing research in CF and the urgency of needing to have things done quicker so we can do our recruitment faster. So you're gonna see a lot of improvement coming up. You're gonna see a lot of interaction with the staff, but if you have any ideas, or if we are doing it in a way that you don't think is the right way, please let us know. We'll be very happy to listen and see how we can get things done better. So the goal is to reach the moon and to also have this beautiful diamond from the eclipse. So thank you very much. And we're going to keep the questions till the end, so this way we can keep going with them. So next is the endocrinology, the CF-related diabetes across the ages. And again, very, very exciting for me to not only drag my colleague from pediatric endocrinology, but the adult colleague as well to come in. And it wasn't a drag, I just asked them and they, again, said yes. So they're going to be talking together about cystic fibrosis-related diabetes across the ages, from pediatric to adult, and to kind of point to you what you kind of need to know or pay attention to as well. So Ines Thomas from pediatrics and Zara Sanduk from adult will come in and talk to you for a minute.
All right. So good evening, everyone. Thank you all for coming here today. I hope you're enjoying your evening, and thank you for the introduction. So we prepared this presentation. It was both my colleague, Dr. Thomas, and I hope you enjoy it and you find it useful. So we were asked to talk to you today about cystic fibrosis-related diabetes across the ages. So cystic fibrosis-related diabetes, or CFRD. I will first start showing you what the outline of our talk is. So basically, initially, I'll talk to you about what is cystic CFRD, what is the prevalence of CFRD, how do you screen for it? How do you diagnose it? And then Dr. Thomas will go over the treatment options, what are the ways to monitor it, the latest devices and tools as well for management, and then how advances in cystic fibrosis are affecting CFRD. So what is CFRD really? It's actually one of the most common comorbidities in people with cystic fibrosis. It occurs in around 20% of adolescents and in 40 to 50% of adults. So you may have heard of diabetes mellitus, which is a disease where you have high sugars and it can lead to many complications. And you may have heard of the most common types, which are type 1 and type 2. So in type 1 diabetes, what happens is the patients with type 1 diabetes have a pancreas that does not secrete insulin. So insulin is the hormone that helps normalize the sugars in your body and place it in the right, store it in the right places and use it efficiently. However, in type 1 diabetes, since they're not producing the insulin, then that leads to high sugars, and so they can become very ill very quickly, and the treatment is to use insulin. Now, when on the other hand, with type 2 diabetes, it happens usually at a later onset, and what happens is the pancreas still produces insulin, but your body does not respond to it the same way, well, the normal way. Now, I like this slide and this picture because it really shows you what CFRD is. It's kind of a combination of both. It's not fully understood, but the thought is that there is, because of the pancreatic involvement in CF, some patients don't produce enough insulin, or in addition to that, they may have delayed insulin secretion, as well as some component of insulin resistance. So it's really a mix of both. And now, why is it important to know about it, and how does it affect patients with CF? So in type 1 and type 2, what we hear a lot about is the increased risk of heart problems, of strokes, heart attack, and death from this. But that's not what is the main concern in cystic fibrosis, or CFRD. And it's mostly the nutritional and pulmonary consequences that are very significant that we worry about. So that includes weight loss, protein catabolism, lung function decline, as well as increased mortality. And that's why it's very important to screen for it. Now, this slide, again, shows you kind of to give you an idea and compare between the different types of diabetes. And as you can see, the onset for cystic fibrosis is gradual. The median ages are between 18 to 25 years of age. There are some genetics as well involved, some genetics that predispose you to CFRD. And then I had talked about the pathophysiology that involves secretion and sensitivity. Here, this is another slide that also shows differences, but what I wanted to point out is that not only there are nutritional and pulmonary consequences, but also have increased risk of what we call microvascular complications. So we're talking about possibility of nerve damage, vessel damage to the eyes, so retinopathy, and then kidney dysfunction. But not so much of the heart and the macrovascular complications. And then as far as treatment, so they are significantly different, and Dr. Thomas will talk to you about this later. So now looking at the prevalence across the ages, as you can see, I don't know if there's a pointer. Is there? No. Oh, yeah, good. So for the younger, so less than 10 years, the prevalence is pretty low, and then across the ages, it does increase significantly. So the green bar is really for the total prevalence, and it's really the highest when you reach the 30s. What's interesting is there is also predominance in women when they reach the 30s, and I don't know why, we don't really fully understand it. In the earlier stages, it's actually almost equal, slight male predominance. So how do you screen, and what is screening for these patients? So usually, so the recommendations are to start at the age of 10 and to do this once a year for patients who don't have symptoms. But if they have symptoms, then definitely workup is warranted. So what are these symptoms? So you want to pay attention to things like increased thirst and urination, failure to gain weight or maintain weight despite nutritional interventions, despite being followed by all these wonderful teams, poor growth velocity in children, delayed progression of puberty are all very important signs to pay attention to, and explain chronic decline in pulmonary function. And then sometimes there are no symptoms, and that's why the yearly screening is very important. And in fact, sometimes a lot of these nutritional and pulmonary status can decline years before the diagnosis. So how do you screen for it? So we use the oral, what the guidelines recommend is to use the oral glucose tolerance test. So the way, this is done basically by checking a sugar, and then make you swallow this 75 gram of sugar and then test another sugar 2 hours later. Some of you may know it, especially if you're a woman, you've been pregnant. It's the same test that we do in the second trimester. And to be honest, it's disgusting, but it's part of the process. And really to diagnose, you need positive results on 2 separate days. And so these, the slides pretty much shows you what a normal response is. So the first, the baseline sugar should be less than 126, and then 2 hours later it should be less than 146. But 140, I'm sorry. But if it's above between 140 and 199, then we call that impaired glucose tolerance, or in the prediabetes stage. And then, however, if 2 hours later the sugar increases above 200, then this is pretty diagnostic. Or if the baseline is already above 126, then that's also diagnostic for CFRD. So this test has some positives and some negatives, so it has to be repeated twice to really diagnose. There are some that believe that it's not the gold standard. And so there are other ways as well to evaluate or to detect these patients. And you'll see that your doctors will do this, and they will often order things that may be a little bit more simple to do, such as a fasting blood sugar, an A1c, hemoglobin A1c level, which I'll talk to you about later, and then a random glucose. So if the fasting is above 126 and the random glucose is above 200, then that's also diagnostic. Now, as you all know, in cystic fibrosis, you can also, whether kids or adults, they go to the hospital, they can have acute illness. And that's also very important. That's where it's also very important to check for their sugars and to pay attention to that, because if under stress, the sugars are above 200 for 2 days or 3 days, then there's something going on. Their body is not able to respond appropriately and needs to work up during the stay, but also as an outpatient. And then there are states where if someone has a J-tube and continuous drip feeding, then post-feeding, if the sugar is above 200, that's also another way to diagnose it. And finally, when it comes to pregnancy, so not only women have to do it in the second trimester, but also before that, because it's important to detect this before getting pregnant, and that's for the health of the baby, but also for the pregnancy and delivery process. So I mentioned the hemoglobin A1c, or glycated hemoglobin. So this is a blood test that's done, and it's often used for type 1 and type 2 diabetes. It's actually even the diagnostic tool and the screening tool, and for management, we use it all the time. And it gives you the average sugar over the past 3 months. So it's not recommended as a screening test for a patient with CFRD, just because there are many things that can affect it. Such as red blood cell turnover, nutritional volume, all of this. And so it's not, it's a little bit the sensitivity is low for patients with CF, but you'll see that your doctor will still order it yearly because it helps, it gives an idea, and then they'll keep monitoring it. So Dr. Thomas actually will talk more about that part as well when it comes to monitoring. And I'll give the mic to her because she's going to talk to you about all the treatments. Thank you.
Thank you. So the next couple minutes, we're just going to talk about the treatment of CFRD, and this is kind of, again, kind of the guideline. So the first thing that's important to know is the diagnosis date is the day that they have abnormal blood glucoses. So if the blood glucose go back to being normal, the patient is still diagnosed with CFRD. And so that means that we have to have increased surveillance. So once we have a diagnosis of CFRD and the blood sugars are high enough and they're staying high enough, we have to start insulin and non-oral medications, and we'll go into that for reasons in a few minutes. The mainstay of treatment is checking the blood sugar at least 3 to 6 times a day, and that's very important because we dose our insulin based on the level. And then finally, we do follow the ADA guidelines for diabetes mellitus, the American Diabetes Association, and they recommend checking the A1c at least once every 3 months. And the rule is that we're supposed to have a goal A1c of less than 7%. So how do you accomplish that? Preprandial basically means fasting or before meals. The goal is a blood sugar between 80 to 130. And 2 hours after eating, the blood sugar should be less than 180. And the reason for this is we're trying to decrease inflammation in the body. So high glucoses in the body sits in the blood, and it goes into the vessels and the cells, and it makes the inflammation. So that happens in patients with type 1 and type 2 diabetes, and it definitely happens in CFRD. And then obviously the inflammation can cause other problems for the rest of the organs. So there are several nutritional differences between treating type 1 and type 2 diabetes. One of the things that we do with type 1 and type 2 diabetes patients is we often will limit their food. We will often say you have to eat at certain times and you have to eat certain types of foods. And we're mostly focused on carbohydrates because that's what you need insulin for. In CFRD, we do not recommend any changes. We leave the nutrition up to the CF team. And that's really important because you'll often hear people, especially with diabetes, say, don't eat that. You can't eat that. Insulin, you have to take insulin for it, which you do, but you're allowed to eat everything as long as you cover it correctly. And in the general population, we are worried about obesity, so we do obviously limit it for the type 1 and type 2s, but in CFRD, that does not your problem. So we're not going to worry about that. You may actually hear us say try to bundle your food together, and that's different. And that's just because you have to give injections. And so we don't necessarily want you to give 20 injections in one day. So during our routine monitoring, you come to our clinic appointments once every 3 months as well. And we do things like looking at blood pressure. And the reason we worry about blood pressure is because it affects the kidneys. So you basically urinate out your sugar, and so that puts a lot of stress on the kidneys. And so we want to keep the blood pressure low enough that the kidneys are not experiencing any other stress. And so the goal is less than 90 percentile for pediatrics, and then less than 130/80 in adults. And again, we treat as needed, but we don't do any sodium or protein restriction like we would with other individuals with diabetes. We start screening for microvascular complications 5 years after diagnosis, and that comes back again to the diagnosis date, knowing when we've officially diagnosed somebody with CFRD. And what we look for, again, is urine microalbumin. This is looking for early signs of kidney disease. We're looking at the eye exam, looking for a retinopathy, and then foot exam, looking for the nerve pain or the foot nerve changes that can happen. An annual lipid or cholesterol panel is recommended for patients with CFRD and pancreatic exocrine insufficiency. So basically, if a patient is on pancreatic enzymes, for some reason that seems to be more protective. But if they are not on enzymes, that's actually more worrisome that they could have more heart disease. And so the recommendation is doing every year, a cholesterol screen. However, you are not exempt if you have any other problems in your family, such as if your family has heart disease, then they do need to go back to once a year screening, and then you have to kind of watch the cholesterol panel. Or if the patient himself has obesity or is on immunosuppressive therapy. So we often screen to be careful, and we're trying to find things early. So we don't usually get accused for over-screening. Unfortunately, insulin is really the only recommended treatment. Some people do use oral agents in the beginning, but oral agents basically take the insulin that you're making in your body and make it work. So if the patient is already not making insulin correctly or not secreting insulin, giving medication to try and make insulin work is not helpful. It also complicated is that in pediatrics, we only have metformin, which is not a great medication for long-term diabetes. And so realistically, most of our patients will end up on insulin really early, especially in pediatrics. We want to preserve any beta cell or insulin production that is still there. And so we need to take the pressure off of the pancreas and also take the pressure off the inflammation from the body. So this is kind of how we do insulin dosing. So there are kind of three classes of that insulin. You have your short-acting insulin, which works about 1 to 3 hours, your intermediate insulin, which works about 6 to 8 hours, and then you have your long insulin, which works about 20 to 24 hours. So we give Lantus, which is a long-acting insulin, once a day, and that is only for people who have fasting high blood sugars. So if the disease has not progressed enough that the blood sugar is not high in the morning, this is not a good insulin to use, or it's not necessary yet. And then you give short-acting insulin for meals and for snacks. Now, for those who are on tube feeds, sometimes you need extra insulin to manage the tube feeds, and that's NPH. That's the one in yellow. And so that is it's an intermediate insulin, so you give it right when the beginning of the tube feeds, and it should technically wear off by the time the tube feeds are done. And everything, unfortunately or fortunately, is personalized. So what happens for one person does not always happen for the other. Insulin was first used in 1922. We have not even hit the 100-year mark. And since then, we have had a lot of changes. So you can see that the first clinical use of insulin was 1922. Not much happened until about 2000, and since then, we have just exploded. So we have the first long-acting insulin used in 2000, and not much else happened for about, again, another 10 to 15 years. And now we have all these new long-acting insulin. This is generic, which is huge in insulin. Tresiba, which is kind of a Lantus competitor. If anybody here is on Lantus, you know that you have to give it the same time of day every single day, and Tresiba, technically, you don't. So that's huge for our families, especially trying to be consistent with their dosing. A concentrated insulin, and a very fast-acting insulin. Those are all really big in the last couple of years. They've tried inhaled insulin, but most endocrinologists are still on the fence about that. In pediatrics, we won't use it. And I would think for CFRD, it would also be one of those things that may not be necessarily great either. Insulin is a growth factor. It makes things grow. So putting it into the lungs may not be necessarily the healthiest. So there's these different types of insulin choices. So the most common when we start is the insulin vial, and you can get that across the world. You have to bring a syringe, you have to figure out the dose, and then you can give it. The next step for most of our patients is insulin pens. This is a 300-unit pen, and it looks like basically a huge highlighter. You put a little pen needle on it, and then you can give the dose in the arms, the legs, the abdomen. This is a device which is kind of similar to this, where you put it on the skin once a day. We don't use this very often just because it's not exact dosing. And then probably what's happening more and more is we're using insulin pumps. And an insulin pump is just a computer. You put insulin in a cartridge in the pump, and then there's a tube, if you can see the little line here, and it basically infuses insulin through an insulin pump site. And it has a very small catheter, very similar to an IV catheter. And you basically replace the site every 3 days. So there are a lot of advantages for insulin pump. So in theory, you're going to improve the blood sugar control because you can be really exact. You put the blood sugar in after you poke your finger, and you put in the carbs that the patient eats, and it does the math for you, and then you can give the insulin. And many of these pumps can go down to like 0.05 units. So it's very, very specific. So there's fewer shots. You can give an injection as many times as you eat. Thanksgiving is a great example. Like I saw one kid who ate 13 times just during lunch. But their lunch was a lot longer than mine. You have the insulin on your body, so you don't have to pull anything out. It can be very discreet. You can adjust the doses based on exercise and illness. So if you are ill, a lot of times the blood sugars go up, so you can actually give more insulin at that time. You can cover the 13 snacks that kids have. You can correct it without having to do the math. Like, it's a lot less complicated than having to bring your pencil and paper and calculator out to do the math. There's things called pizza bolus. So pizza has high fat, and so it's hard to match the insulin sometimes by just giving a shot. And so this actually gives insulin, and then it spreads out the insulin to kind of match what your body normally does. So it's very cool. And we all know teenagers eat a ton of pizza. So that's why it's called the pizza bolus. If you're exact with your doses, there's less chance of having low blood glucoses. And there is tons of software that comes with these pumps. You can grab everything, you can do statistics on it, you can see what the patient did, you can see if your child actually gave insulin at lunch, so you can go back and kind of, check your child. But there's disadvantages, like with anything. You still have to give insulin with food. It doesn't do it for you, so you still have to put the blood sugar in and you still have to put the carbs in. So that still takes time for families. There's a high risk for skin infections, especially if the site's not changed out every 3 days and it's not prepped correctly, but that's pretty low. The insulin's on your body. You have to make sure that it's still at room temperature. If you are out at the beach, you just can't stick it on your towel. It has to be in a cooler. You have to change out your site every 3 days, and you have to move your site around. So that's also very important for families to know. Tubing can catch on anything. And there's some very physical and psychological considerations that have to be thought of. For sports, you have to kind of work out with families like how they're going to hold their pump and where they're going to put it. And the other thing is, it's something that you wear 24 hours a day and you sleep with it. So for some teenagers, they think of it as life support, and they don't like that idea. And that is fine. No one has to be on a pump. You just have to kind of work with the child to figure out what are their goals. And it's expensive, but most insurances do cover it for diabetes now. And if your pump gets dislodged, you have an increased risk for ketones. Individuals with CFRD are not as high risk for ketones. Ketones are a breakdown of fat. It's basically if your body doesn't have enough glucose to go to the brain, your body has to have an alternate fuel source. And what the body will do is break down fat to make ketones, which the brain can use. Unfortunately, though, that is very acidic to the body, and so we don't want ketones, and we really have to be careful. But thankfully, individuals with CFRD are at lower risk, although it's not zero. We definitely have had kids who had tons of ketones. So why aren't we using this more? So this is a study from 2015, and it's in Germany, so it's a little bit different than us. CT is conventional therapy. That's 2 times a day shots. That's not very exact. That's basically saying you're going to give this much and this much every single day, and you have to eat a certain amount every single day. The MDI is multiple dose injections. We teach the family how to do the math so they can adjust the doses. And then CSI is continuous subcutaneous insulin infusion. So in this study, 68% of the patients were in the multiple dose injections, and the rest were between the two, with only about 18% on pumps. It was even less in CFRD. It was about 4%. Now, I think if they did this study again now, you would probably see much more people in the US on pumps, but I would think the percentage for CFRD is still about the same. And some of it is that it is very complex. It's a computer that you have to wear and learn how to use, and you don't have to learn how to troubleshoot it. And we have kids with CFRD who are on pumps, but it does take engagement of the family and of the team to actually get it going. The age of a child or of an adult, sometimes that also makes a difference. How long they've had diabetes, where they are in diabetes. If they don't have fasting blood sugars, it may not be necessary yet to give long-term insulin. Skin infections, cost, and then of course the engagement. This is probably the coolest thing that's happened in diabetes. This is called a continuous glucose monitor. It's a device that you put on the skin, and it's about the size of 2 quarters in length, and you basically checks the blood sugar every 5 minutes, and it puts the data on your phone or on the device. And so what it does is it just tells you what's happening with the blood sugars. Things have really come a long way in the sense that soon we're going to be able to dose off of it. I know in adult world they do dose off it already, and so that's going to help make things just one more thing easier if you don't have to keep poking your finger. And so then you can look at the data and say, hey, this is how much insulin this is how much I need to correct my blood sugar. It kind of tells you what's happening, And it also gives alarm. So if the child or the adult is going high or low based on the blood sugar, you can do something about it before it's too late. This is what you get. You get every single day, and then it does statistics for you, so you can help figure out how to dose. And then there's also the question is, should we use this to diagnose? Do we really need to do the oral glucose tolerance tests and all of the other hoops that we have to go through before diagnosing? The positive thing is we can see the rise in blood sugars really early. And it's not just one set of values. You can actually get several days worth out of one of these devices. And you don't have to be fasting, and you can do this at home. But it's not even an approved method in type 1 diabetes yet. So I think we still have a long way to go. And we may actually diagnose people earlier than we need to, even though there's still some question about whether or not CFRD actually starts before you have abnormal blood glucoses. And insurance coverage is really hard for people with type 1. It's going to be hard for people with CFRD. And it would require 2 clinic appointments just for this. This is the new pump that just came out a couple summers ago. It just shipped out last year. It is a pump that takes the continuous glucose value and it actually changes the doses based on this. So this is a game changer for us because it's going to make things also easier. And I'm hoping that this will also translate into CFRD diabetes care. And even more exciting is I have a catheter, and I'm totally saying that wrong. I apologize. This is something that seems to improve insulin secretion, and it's shown some CFRD to resolve or even or at least improve. So this may be what cures CFRD, at least where everyone's hopeful. And so more studies are on the way, but if that's true, you might not need us, which would be amazing. And so, all right, thank you very much.
Okay, Dr. Simon is our adult center director, and he's been a great supporter for all the activities we're doing in pediatrics as well. So it's my pleasure to have him over.
Thank you. As you all know, there's been a lot of excitement in the CF field with development of new medications, particularly those that we call modulators. Just 2 months ago, a new one was approved, and they're just starting within the last probably 3 weeks, another study with another generation of modulators that I want to tell you about as well. But because these are so important, I thought I would spend a little bit more time doing some background information. Exactly what is the problem that they're working on, so you have a sense of where we're going with this whole field, where we've been and where we're going as well. So just to show you, to start out with, you can see that we've got here a lung, and then if you look, it's made up of small airways, and this is one that's blown up and opened up here. And we can look at the surface of the airway to see what it looks like. And it's not just a flat, shiny surface. In fact, when you look at a very powerful microscope, what you see is the whole surface has all these finger-like projections. They're called cilia. And what these cilia do, they're important for cleaning the airway, for getting material that you breathe in that goes way out in the lungs and get that up and out so that it doesn't stay there causing damage, or if they're bacteria, for causing infection. Now, the way these cilia work, they beat in unison. And so this just shows you one cilia that's sitting on the top of the cell, and there's a mucus layer that floats on a liquid here. And these cilia beat and they move the mucus that has bacteria and other things that are present in it and takes it from the depths of the lung, gets it up and out. But for this whole thing to work correctly, there has to be the right amount of fluid sitting on top of the cells that those cilia can work in. Because if the fluid isn't there in the right amount, the cilia won't work, and that's exactly what happens in cystic fibrosis. Here on the left side of the panel, I apologize, I can't do pointers on both sides, but this is the normal situation where this is the top of a cell. These are these finger-like projections that are going to be moving forward and taking the green mucus layer and getting it up and out of the lung. But we now know in cystic fibrosis that fluid is not there. It's dehydrated. So what happens is there's no fluid for those cilia to beat in. the mucus accumulates and it gets stuck on the surface, and this is what happens, at least one of the main problems in cystic fibrosis that leads to lung disease. It can't clear out the lung, you get infection, and it causes injury there. So the question is, why does cystic fibrosis cause this problem with not enough fluid? And the answer is, there's a protein that needs to be there and work, and I'll call it the CF protein, that without it, you end up with not enough fluid on the surface of the cell. So again, I'm going to use the same diagram, but now I'm going to look at the airway in cross-section. So here you can see the cilia that's up on the top. These are the airway cells here. And the orange level that's between the two, that's actually where the CF protein resides. It's supposed to be right on the top of the surface of the cell because it's going to control the amount of fluid that gets out of the cell and allows the cilia to work. So again, just blowing this up further, we know a lot about this protein now. It's the CF protein or the CFTR protein. And here it is, everything in yellow here is the CF protein. And it's sitting right on top of the cell, and we know the way this protein is configured, that it forms a channel. And this channel allows chloride and bicarbonate to go in and out. And that actually, through an indirect mechanism, that's what determines how much fluid is up on the top of the cell. If that CF protein is not functioning, you don't get enough chloride and bicarbonate up there, and you end up with a dehydrated cell surface there. So where does this protein come from? What are proteins? So this is just showing you proteins are made up of building blocks. Here's just showing you there's actually 20 different types of building blocks here. They're called amino acids. They're small molecules, and each one differs from the other. But when proteins are made, they're made from amino acids. And what happens is the amino acids are connected one after another to get this big chain. It's a huge long chain for many proteins. In fact, in cystic fibrosis, this chain is 1,480 amino acids long. And it's the type and the order of the amino acids that determines what that protein is going to do. This is just showing now the amino acids now as little beads on a string here. And because they're all different, these amino acids, some like to be partnering with other types of amino acids, some will push away from them. And what happens is you start forming structures as these amino acids line up with each other. So sometimes they can form coils, sometimes they go back and forth and form sheets. And so when you take a big long protein here, you can get a very complex structure. Because you need a complex structure because it's that structure which allows the protein to function. For example, in the CF protein to form a channel here. And then these different components, they all fold together as well. So what starts out as a big long string ends up as this very complicated combination of different parts of different structures here. Excuse me. So this again is looking a little bit more so you can see it larger here. This is what the CF protein looks like. And we now know even more detail of it because this is actually a diagram of the CF protein where these amino acids have formed a helix here, they form sheets here, but you can see this channel here, this is actually what it looks like. There's other sections, there's other parts of the protein, the CF protein, that are inside the cell, and they're important for that channel to work properly, to be open and closed when it's supposed to be there. So what determines, why does this go wrong in cystic fibrosis? Why is this protein not made right? And the answer is that it's DNA or genes that dictate how proteins are made. So this is just the double helix DNA. And you can see there's these little bars across here. There's actually 4 different kinds of bars that are there. And this forms a code because the cells read this code to decide what order to put those amino acids in so you get them in the right order on the protein here. There's an intermediate step called mRNA, but the code is read so that you end up with the protein, the amino acids, in the right order. And so when you hear there's mutations in a gene, what they're talking about, the mutations, is there's something wrong with the information in the DNA, that there's something that's changed here so that the amino acids that are supposed to be coded for are different or changed, or there's something wrong with it. I'm going to mainly be talking about the most common mutation, and that you've all heard delta F508 or F508del. That's a terminology, and it means that there's a single amino acid missing. It's in position 508, so if you start at one end of the protein and count up 508 of those full 1480, that there's one of those amino acids is missing, and that's what happens with the mutation delta F508. This is just showing you here the DNA is in a code, and it comes in triplicates. So one triplicate will code for a certain amino acids, and it tells the cell how to put them together in the right order. So normally here, as we get through into the area 508 amino acids down the chain of this protein, it's supposed to be, these are all amino acids, asparagine, isoleucine, phenol, you get the point here. But in delta F508, there's 3 base pairs that are missing. That removes one amino acid, so the protein that's made in patients who have delta F508 is missing one amino acid. It skips from 507 all the way to 509. It's hooked up together, but that one is missing. And you think, gee, out of 1,480 amino acids, one can't be that important, but you're darn right it's important. So this is looking at, again, that diagram of delta F508, and we're talking about something really small. In fact, I'm pointing to where that delta F508 would reside in this. It's just one small part. But when it's not there, things go wrong. I showed you these amino acids are put together and the protein is made as a chain, and it has to fold upright. And it turns out that patients who have the delta F508 problem, that one amino acid missing, it prevents this protein from folding correctly. And if it doesn't fold up correctly, it doesn't end up on the top of the cell, and it doesn't do the job that it's supposed to do. So I've just written here that in the delta F508, when you're missing that phenylalanine, it doesn't fold up, the protein doesn't get to where it's belonged, no channel is formed, the airway surface is too dry. That's the most common mutation, and that's the main reason that it causes the problem. So the issue is, so what could we do to try to fix this? Right now, it would take gene therapy or some gene editing to go back into the DNA and put that missing 3 base pairs back in so that that amino acid would be where it belongs. There's a lot of work on that. The CF Foundation is funding this in a major way, but we're still talking about many years, even the most optimistic person. So that obviously would be the best way to do it. But so once the protein's made, is there something we can do to get it to be right? And so the theory is, well, you've got a protein here, and you're missing one amino acid. Can you figure out some chemicals that you might be able to put in so that when they're in the right place, they would take the place of that missing phenylalanine. They would let the protein fold up correctly. And that's exactly what's been done to find these CFTR modulators. I've talked in previous years about a different mutation. They're called gating mutations, and how the process found small molecules to fix them. But now what we're working on is the major type of mutation, the delta F508. So the idea is to search for chemicals that when you put it in with this protein, that it will fold up properly and it can do its job. So how do you go about doing that? Well, there's companies that have set up a system, it's called high throughput screening. What they do is they take cells in culture and they can manipulate them so they can have any CF mutation that you want. So for example, you make cells whose CFTR looks like the delta F508. It's missing that one amino acid there. And then you go and look to see, are there chemicals, when you add them to the cells, will it correct the problem that's there? Well, fortunately, there's chemical companies that have made these huge libraries. In fact, there's ones that will have 500,000 different chemicals all in their separate tube. So you've got access to this huge number of chemicals you could test. And then what they've set up is robots that they'll take the chemicals out, they'll put them on the cells, they'll let them incubate for a while, and then they'll test, has this fixed the problem, in this case for delta F508. And the good news is that progress is being made. and you're already familiar with one of them. This is lumacaftor ivacaftor. It was improved about almost three years ago now. And this is actually a combination pill. The lumacaftor is what's trying to fix the folding abnormality. And this is, as you know, has been out for a while. And when you look to see how much benefit it has, this is showing the breathing test results and how much lumacaftor in conjunction with the second one, ivacaftor, how much it helps the breathing test. These are data for people who have 2 copies of Delta F508. And you can see that it does increase the FEV1. It's about 2 to 3%. It's more than 0, and it allowed us to be able to get FDA approval. And so we've been using this, and it's been available for many children and adults with cystic fibrosis for some time. But the amount of improvement here isn't what we want. We want much more than that. And so just 2 months ago now, another medication, and this is, you may recognize now, it's tezacaftor, ivacaftor, or Symdeko, and this was approved February 12th. And now it's the tezacaftor that we're trying to use to be able to get that Delta F508 to fold properly. And when you test it, it does cause some improvement, and the improvement is a little bit more than the lumacaftor ivacaftor, the first one that's there. It's measurable, but it also has a lot of benefits because there were problems that at least some people couldn't tolerate the lumacaftor ivacaftor or the Orkambi. And also there were problems with people who had to take other types of medicines. Some of them would be inhibited or would cause troubles if they were on the Orkambi or the lumacaftor ivacaftor. This new one, Symdeko, or tezacaftor ivacaftor, doesn't have that. So it does cause improvement in FEV1. Also, both of these decrease the number of times people with CF would need to go into hospital or to start IV antibiotics. It seems to protect them somewhat from these exacerbations that we try to prevent. Okay? But what's really exciting, and I would hope that you're reading about it already, is there's next generation correctors that are coming out. There's actually 4 of them. This top one, VX659, is actually one that just started probably within a month ago. Has been started active phase 3 clinical trials with it. There's another one, VX445, that they are planning to start, or at least that's the intent. And there's 2 others that they have sort of as backup. This VX152 and VX440 that I believe is going to be down the line, but not quite, but they're sort of backups with it there. And these are really exciting because although both lumacaftor ivacaftor and tezacaftor ivacaftor cause improvement, the amount they're seeing when they add this 3rd medication to it is really substantial. This is looking at cells in culture that in this case, there are cells that have 2 copies of the Delta F508. And you can look to see the improvement of the CF protein function when you add them. So this is the cells without any addition. There's just a little bit of CF activity. Tezacaftor ivacaftor, this new one that came out, increases it. But when you add these new correctors, and these are data from 152 and 440, but 659 and 445 are similar, it shoots it way up. And this is a lot because we know that from the Kalydeco, the ivacaftor that helped people with the gating mutations that's been around for a few years, this is doing an equal amount, if not more. And the other key part of it is if you just have 1 copy of Delta F508, not 2 copies, but just 1, it turns out when you add this third chemical to it, this 3rd drug, it helps a lot. And this is the laboratory data showing that these are now cells with people with just 1 copy of Delta F508. And you can see that adding, in this case, the 152 or the 440 brings it almost up to what we saw when Kalydeco or ivacaftor was given to patients with the gating mutations there. So this is all in the laboratory, and so, it's a long way to go from cells in a culture dish to humans with cystic fibrosis. But the good news is that there is early data from phase 1 and phase 2 trials from these triple combinations that's showing really promising results, and it's moving forward to the phase 3 trials. So this is showing what happens to the sweat test. You all know that people with cystic fibrosis have high levels of chloride or salt in their sweat, and the medicine that's working is going to reduce that. And this is showing just for patients who have 2 copies of delta F508 here, the current tezacaftor ivacaftor does reduce it back toward normal some. But look what this, when you add 659 or 445, these are in humans. This isn't in a test tube. These are patients with cystic fibrosis. There's a huge reduction back toward normal. This is really important. And of course, people aren't complaining that their sweat is too salty. They're complaining about their lung symptoms. And so this is what the FEV1, the breathing test, shows with this. So this is what happens with people with 2 copies of delta F508 when they're using the Orkambi or the Symdeko. There is measurable improvement. But this is what the early results are showing. This is just 1 copy now of delta F508 with a triple combination. These are huge increases. We've not seen anything like this for patients with delta F508. Now, they've started already the 659 trials, and it's going to be probably a year and a half before we've got results from them. If it holds up with these benefits that hold up, we've got a really important drug in the pipeline. The only issue is it's a new chemical, no one's ever seen it before, and we have to show that it's safe. And that's going to be the big issue, because if this data that we've seen early on holds up, we just have to know it's safe. But there's always these backup molecules, and there's other companies that are doing it as well. I just want to end by show you a graph that shows you what's happened to survival in patients with cystic fibrosis, going all the way back to the 1940s when the diagnosis, when it was just recognized that this was a distinct disease. And at that time, almost all children born with CF were dying in early infancy, mostly because of the digestive system problems. We didn't have enzymes at those times, and the children were not thriving because they're not able to digest food. But you can see there's a steady increase going on for a lot of different reasons as one medication after the other has come forward with it. But everyone probably has looked at this one little jump here in the last year, our last year of data. Now, this may just be a statistical variation, that this jump isn't going to hold up, but all of us are hoping that it's real, because it jumped from a median predicted survival of 41 all the way up to 47. And our hope is what we're beginning to see here, at least in part, is the effect of these new modulator treatments. We will get another set of data very soon that will be out within months. They'll probably wait till the fall before they're shared with us. But our hope is that this is a new trend that's going straight up like this. I'm an internal optimist, and I hope that's true. But regardless, these new developments here are really important additions to our CF treatment, and they're going to make a huge difference, particularly this set, as long as they're proven safe, and that's going to be one of the big issues. Okay, thank you.
Okay, one thing I forgot to mention is Cheryl Evans. Cheryl is our secretary / event planner / anything and everything you need her to do. And she's the one that prepared the list for me, and she will never let me forget it. So I am really sorry, Cheryl. I actually, you were in the list. I just skipped over your name. Sorry. But Cheryl has been wonderful. She actually created this it's CF Parents Night Out that is supposed to be in May 24. And it's a beautiful design. I love roses and I love red, so she did a wonderful job in creating it for us. And like I said, she does anything I need to do. I just go to her and she takes care of it. Then I forgot to introduce her, sorry. And this is the Family Night newsletter the Family Advisory Board newsletter that was created by the Family Advisory Board members. So last but not in any way least, we have Cindy George, our guest speaker. She's from the Cystic Fibrosis Foundation, and she was graciously agreed to come to talk to us. Cindy is the CF Foundation Senior Director of Partnership for Sustaining Daily Care. And really to think about what that means, it means that she does everything. Whatever needs to be done, she just starts. And she's been involved in so many different initiatives. And then once things get going, then she move on to another initiative. So she has been wonderful to work with. I've been working with her for years, and it's a pleasure for me to introduce her. Thank you for coming to us.
Thank you very much. Thank you very much. It's just a delight and a real honor to be here with you. And Sarah Green is on my team, and we were just so excited to be with you tonight. Thank you so much. Do I just push this like towards here? And then just so it goes? Okay. All right. So first of all, I want to find out, how is everybody this evening? Are you good? Good, good. It's a great day that I landed in Michigan. I had just been in Minneapolis. It was last weekend, and they still had snow. So it was really, really nice to come back up north. I'm actually originally from upstate New York, so I was used to the winter, but it was nice kind of not to see snow as we're almost right at the end of April, so it was really nice. So I don't know if you may already know, but Dr. Simon and Dr. Nazar and the care team are incredible leaders in our CF Care network. And when Dr. Simon was just talking about all of that research, he plays a very special role and has for a very long time in being the lead of our CF Foundation's Data Safety Monitoring Board. And I am not going to even jump into it, but he makes sure that the trials that we are funding through the CF Foundation really are safe. So when he talks about the safety, he's right at the helm that we trust to make sure we're going in the right path. So for that, I thank both Dr. Nazar and Dr. Simon for all your tremendous leadership in the CF community. So thank you. And on what Dr. Simon said, it really just is incredible news. I've been a nurse for a little over 30 years, and my first foray into understanding cystic fibrosis when I was a new nurse, I was in school in Buffalo, New York. And I was assigned as a junior to take care of a baby. And they said, okay, so you got to give the enzymes, you got to do all this stuff. And I just remember going, oh, how are we going to do this, you know? How are we going to take the applesauce and the beads in the applesauce? And this little baby, he certainly taught me a lot over the time we were together, a few months. And then at the same time, during that rotation, I was also caring for a 19-year-old during this pediatric state who was at his end of life. And so I had a chance to really kind of see in that short span, that shortened life but to hear what Dr. Simon was just saying and see the incredible transformation of our new modulator therapies and where it's headed is so incredibly exciting. And I hope you feel that excitement. But tonight I'm going to talk about the fact that, and I think this is even more important today to talk about, is the issue, what we would say is treatment adherence. Because these transformational medications are, and I think we just kind of caught it when you were talking about, it's in addition to right now all the other treatments that we have, and that's a lot that you deal with. So Partnerships for Sustained Daily Care, I'm going to tell you a little bit of a story about how it's come about. It's a little bit of a concept, but it's also a program. And invite you to sort of reflect on your partnerships, because at the core of the program, it's really valuing the relationships that all of you in this room have with one another. As clinicians, as parents, your children as they're growing through the various developmental ages, and as adults living with cystic fibrosis. And it's understanding the key role that they play as you work together to develop care plans or treatment plans that continuously evolve throughout one's lifetime so that they're able to be sustained in your life so that you can reach the best health, whether it's you, your child, best wellness, and ultimately your life goals and aspirations. So we're going to I kind of look at this as kind of taking something that we know has been there for a long time in our community, our relationships. But when we kind of bring it out of the closet and put it maybe right where those lovely candles are in the center, and we look at it and intentionally invite ourselves to kind of see, how can we even nurture these deeper? How can we teach our kids to become partners with our care teams. Just as Dr. Nazar was describing all of these great projects, I kept thinking to myself, wow, what great opportunities for you and for your children and for adults living with CF to really partner with both these pediatric and adult care teams in all these wonderful projects, again, for the best health. So tonight, I hope also, we have handouts on the table, and I'll go through what they are. I hope also the second part here is that you'll invite, or you'll start to join us in telling a little bit of some stories, perhaps, about your partnering. We're going to look at it with an appreciative lens, which is looking at it when it's gone really well, because it's really easy to go when things don't go so well. But what makes your partnerships with your children and your care team really work, because that's what we want to build off of throughout our community. We have found that when we speak with adults and parents and children across the nation, that many people have great relationships. But we've also heard that sometimes there are broken relationships. Sometimes there's an understanding of not sure how to actually talk about when you're having difficulty trying to balance all these treatments. And so that's a big push of what we're looking at. And our goal is to reframe adherence from being perhaps a very negative topic to one that's just part of what we're doing, and it really isn't negative. It's just working together as partners. So I invite you to reflect a bit. So I'm going to share some things, but I also invite you individually to reflect and encourage maybe your kids occasionally. You wouldn't use these words perhaps with them, but reflect on how you partner with your clinical team. And I would say clinical team, just reverse it. How do you partner with your patients and families? How do you share what's most important when you come to clinic or before clinic? How do you contact your team? How do you share the challenges that you're having with this therapies, taking them consistently? How do you approach and how do you react perhaps when there's some difficult conversations that you have to have? And here's one, what would help you rather partner even in a deeper way with your care team? So things to reflect upon. Because we know that living, as I've talked to many folks and through my own experience at care teams that I used to be in, living with CF, as we hear, multiple pieces. You have lots to do that's related to just treatments, but you have lots more to do that's just living daily life. I used to have a lot of the adults that I used to care for tell me, this is really great, Cindy, all you want me to do. But you do know that I need to do laundry, I need to cook, I need to go to work, believe it or not. I'd be like, okay, so let's talk about that. How are we going to get this fit in? And so many folks tell us that it's like trying to make a balance. And the best effort, sometimes that balance isn't always there. And I think it's just recognizing that and bringing that out into the open. And that's what Dr. Nazar was saying earlier. Let us know what's happening so we can help work with you on that. Because we recognize that as much as she'd love to have 100%, it's really not always possible because of the daily life. Really, it's because life, right? Life happens, darn it, and we're all humans. So here are some of the things that folks have told us that are top challenges to kind of sustaining this care day in and day out. Time. When do we get the time to do all this? Sometimes forgetting. There's a lot to do. Financial. It's a very costly disease, and I think we heard Jackie today talking about some of the help trying to offer through Compass. Beliefs and attitudes. I think we heard a little bit of an example of sometimes, you have a different belief system and attitude, and that's critically important to talk to one another about. Our knowledge and skills. When we're teaching the kids as they get older, they could forget. They could get to adult clinic and Dr. Simon's talking to them about Pulmozyme or something, and they're maybe not quite sure why they were taking that. So sometimes we have to refresh our skills. It's exhausting sometimes, right? That's what we keep hearing. It's exhausting with CF. So sometimes that low energy, you might not have the energy each day. Depression and anxiety, we're learning more and more about that, really in our whole society, whether you have CF or not, but also in particular with CF, right? And that can kind of prevent folks from carrying through on a plan that you might really want to, but maybe the anxiety or depression is kind of hindering it. And sometimes the side effects of the medications may not be something that makes you really want to take those medicines. Do these sound right? Anything else? I don't know if we have microphones or anything. Does this sound right, or would you add anything else that we're missing?
Pharmacies
Ah.
every month, and one pharmacy every 10 days. It's almost physically impossible.
Yeah, logistics. trying to get all those medications. That's pretty quick, right? Turnaround. By the time you've done it, you probably do feel it's like, wait, I just did this. Anyone else? Would you add anything? Well, we're going to add logistics to the next slide. So the impact for all of this, having to do so much, trying to seek this balance, having these various factors impede sometimes every day, kind of the impact, and Dr. Nazar showed this too, I just rounded to 50%, but the research is roughly showing about 50% of respiratory, the inhaled medications are being taken. And the impact, though, unfortunately, is that the less they're taken, you have lower lung function and more pulmonary exacerbations. So our conundrum, kind of our challenge as a community, is how do we fit in more treatments, yet know that life is here, and how do you fit this in? How do we get the balance that best works for you at that time of life, knowing you can continually change it as life circumstances change? And so research has shown that there are, this is just a modified factor, there are multiple factors that influence a person's ability to sustain care or adherence, and that's whether you have CF or not. This is just showing there's major 4 domains, but in addition to the individual level here, you have family situations, you have your community situations, or you have factors in our healthcare system. And I think exactly what Dr. Nazar was talking with this quality improvement, a lot of the quality improvement in our community is about how do we fix our healthcare system in what we can do. There's a whole big, as you know, national thing about that. But in your system, how can you kind of work to improve it depending on the topic? And so at the CF Foundation, there are a multitude of services and programs that are in place for this. And so several years ago, when Dr. Bell asked me to kind of leave working with Dawn and all the great folks in clinical research and take this on, and Dr. Campbell will say it as well, like, oh, how are we doing with this topic? And I'll be like, just so you know, the whole foundation is doing this topic. This is just not sitting with me. So I wanted to just point out that when you look at healthcare systems and the individual, there is public policy and compass that Jackie was representing. So at the national and your state levels, you do have folks working on behalf of you to get better access through the insurances. There is a robust mental health initiative here. Jennifer, Dr. Butcher, is she here? There she is, hey. And others are really working on, again, that. There's also tons of education. If you have not seen cff.org in the last couple of years, it's been refreshed, and there's lots of great information that's continually updated on there on a variety of topics. There's, I think, the chapter just mentioned Peer Connect and virtual conferences, so a great way to connect, because we have heard that the best way for any of you that you've said, or adults living with CF, are saying, I really want to hear from someone who's living with what I'm living with. That's really meaningful to me. And then the last 3 I'll talk about because I have some control over them. The one is called Success with Therapies Research Consortium, and that falls under our program, and you are part of that. Your center is part of about 17 centers. It's a small consortium, just started a couple years ago, and the main focus is to see if we can see if there's any interventions that are effective in this ability to sustain care, or again, the issue of treatment adherence. Are there certain things that you might be able to, or your child, again, or if you're living with CF, be able to use to help keep up with all these therapies? And I'm going to show a slide in a sec. There we go. These are 4 that we have underway. You guys have just helped us finish a standardized barriers to checklist, adherence checklist. So what that means is, through research that 2 of our key psychologists in the community have done, they put together these standardized checklists that hopefully we can use across our centers. So there's a tool to have in conversations in clinic or on the phone, so you really can have a dialogue about what's getting in the way with some of the treatments, so your team can then problem solve. Well, do we need to call a compass, or do we need to, think of a reminder, or do we need to cut back on this, or what do we need to do? So hopefully that will be, I'm hoping, in the next year, available to everyone. We're doing a telecoaching pilot, so things maybe outside of clinic that may be helpful, telecoaching from home via the web. This web-based nutritional program that you really are involved in, thank you very much. Very excited about this. This is a web-based nutritional program for young children Many of you might experience it, or hopefully not, but you might have some recollection of a feeding difficulty with some of the children, wanting to get all those calories in and they don't want to get it in. This has been an effective program to actually enhance calories, thus enhance weight. And what we're trying to do is increase the technology so we can move it out of a research setting into your clinical world. And several parents were part of this 4-center program so far, and we're working to get it 6, and eventually, if we can get the technology to really work with us, hopefully out to all pediatric centers. That's the goal. But I must tell you, it's my first foray into technology, and it's really kind of challenging, huh? Yeah. And then a mobile medication app that we're working on, because people say, hey, there's an app for that. We should be able to do it. Well, we want to know, well, does an app really help? This is a medication app that we're going to start the pilot soon. It's going to be about education and reminders, and we want to see how that will work. So that's exciting. Thank you very much, Michigan, for being part of this. So back to other parts. So we've heard then about having conversations can kind of be difficult sometimes when we're talking about treatment adherence. So we are working right now on trying to get some training and some pilots together for skill building around having better conversations for both all of you and for your care teams as well. And all of that's important because it all rolls up to the ability to really enhance our partnership skills. And so that's where we're going to zero in on right now. So all this started in about 2014. We brought together representatives from across the community, and this is pictures of when they first started to come and meet, and you could see lots of folks online. So we had lots of adults, we had lots of parents, we had representatives from the multidisciplinary care team, both pediatric and adult. And we did bring in a representative from pharma and specialty pharma. And this group met for a couple of years, and they actually said some very wise things. We started out with, you know what, this is really important for people's health. We got to help people take more therapies. And they said to us, yes, that's true, but we want you to rethink this. We want you to think about the fact that taking more therapies, you have to think about the whole person, the whole life context. So it's not so simple to say, take more meds. And they said, sometimes thinking about adherence can be very judgmental. They can feel judgmental. It can feel like I don't really want to share because I don't want to disappoint you, care team. I care so deeply about you. Or I'm just really not sure how to find the words to say this to you. So they really encourage us to really reframe our thinking, reframe our language even. And because words really do matter, and words do I think, drive how we think about something. And so their suggestion was to switch again, to look at the whole person, understand what my life is, understand then the impact of my life in a much more intentional way. Because they said, when we sometimes bucket people as adherent or non-adherent, and there's a reason that the care teams kind of do this, they kind of do categories in a way of what we saw today, and that's because you want to look at an approach. You want to make sure you haven't missed anything. So there's a really good a good intention behind that. But some folks here are adherent and not adherent, and it leads people to believe that maybe that they haven't recognized the fact that at some point we all are human, we all struggle. And so it's recognizing that we all have some points in our lives when we're hitting the ball, right? We're good, and then the other parts where we're maybe in a little bit of a valley. And so recognizing that everyone, and I think again Dr. Nazar talked about that, you don't want to miss everyone by just focusing on one set of folks. So when we can really kind of break away adherence and think about how do we help everyone sustain that care? Well, we think it's through the relationship and your partnerships that's a key piece. And so Partnerships for Sustained Daily Care came about as the words, because it's partnering to may remind us that we're in this together. And how do we equalize? How do we both come together to be active partners? Sustaining, and I had lots of adults say, you know, this is a 365, 24/7, 365. Clinicians, we all get to go home. Those of you living with CF, you don't. This is your life. And so sustaining the enduring piece. And again, the daily care versus just the treatments. How you doing treatments? Well, I got to put that treatments into that whole life that I have, and I want to do a lot with that life. And so I think this kind of comes home a little bit with this treatment plan perspective, because I think at the end of the day, it's where you sit and the way you view something. And I had an eye-opener. I want to tell you, and most of us sitting on this committee all left going, wow, that was really an eye-opener. And if I went back into practice, I hope I would do something a little different. CF treatment plans. This may or may not look like what you walk out of clinic with, but for those of us who are clinicians, something like this is a list, right? And then this is a real story, and this came from an adult who was getting ready for disability. She didn't really want to not work, but it reached a point in her time where she really needed to apply. And she brought this list that I'm about to show you, and she said to her care team, do you think this is going to get across to these folks, like, just what I do? Now, they would have labeled her as adherent, and their mouths just dropped open, the story is, because they said, oh my gosh, I had no idea what this looked like in your life. And it looked like this. And I went and took the liberty of highlighting anything yellow that had to do with her doing something with treatments with CF, right? So it was gathering that equipment, that's part of it. It's doing something, sinuses, really, or nebs, or taking pills, or doing the percussion, and cleaning the equipment. So all of that as a package is about the treatments. And when they saw this, they were like, wow, I really didn't know. But this tool gave them a great conversation. They said, wow, let's have some different conversation. Let's see what we can maybe readjust. So you might get some more sleep. So it was really very enlightening for them, and certainly I found it very enlightening. And so what we want to do with this topic of adherence, because folks have told us, and maybe you don't feel this way, but many folks have told us, like, oh, I got to have this dreaded talk, and I don't want to have it. Whereas something that feels much more linear, like I come in, I review the list, and then I get this plan, and maybe I feel like I created it with you, and maybe I don't. And then it's this thing like, oh, I'm supposed to go do it, but then I'm having some trouble. And so maybe we talk the next time, or maybe we don't. To something that really kind of sits more of this ongoing, it's just natural part of what we're doing. It's a two-way. It's definitely two-way. And I like to call it actually a learning conversation, because we're always learning. There is nothing that we just know. I think Dr. Nazar, again, you said it, was, we might, or one of the talks was saying that everything is individual. We have a general idea, but then how it affects your life or how it affects your body or your child's body, we kind of have to think about that. So this is just really to say that when we come together, it's important that the two sharing, bi-directional, right? We're hearing that Dr. Nazar and Dr. Simon and the team are hearing what's happening in your life. What are your goals? What would you like to get out of this visit? What's been happening since the last time I saw you? What's working, what's not working? They're sharing with you, oh, well, we got some new guidelines out, and here's what we've just read in the research that we had. And so we're recommending this, and then together you can make that plan and then discuss how it was when you carried it through. So does that make sense? Nobody's saying anything, uh-oh. All right, I'm going to nod, okay. So now let's kind of go into understanding how do we then build these partnerships in a much more intentional way. That's just where I'm coming out from. It isn't like you haven't done this. It's just much more intentional when we think about this topic of adherence. Because if your team doesn't know what's happening in your life, I liken it to the fact that they're blind. They may be adding more treatments when in essence that may not be what's needed. It may be a shift. And it's not always easy sometimes to talk about. Again, that's why the importance of communication. So what we've been doing is asking for stories around the country. We've been asking adults living with CF and parents and clinicians. So if this is really important, as we're hearing you say, how would you define a partnership? Because it's kind of a word that can be very personal depending on how you look at it. And what we found is we kind of analyzed the theme, and I went and I got some qualitative researchers to kind of go through these stories, and they found some interesting things. And what they found is that two key elements, when they're present, they really invite this sharing closer. And that one is understanding each other as humans, the shared humanity, that you connect on a human level. That it isn't somebody who's coming in the room, perhaps you've been sitting there for a long time, maybe you know them, maybe you don't know them, but it's sort of like, hey, what's going on? I gotta do this. Here we go with a checklist, because that's what we're driven in healthcare by, that's what we're measured by, that's what we get paid by, and sometimes we get really busy. Instead, it's more, well, how's it going? I know you just, had a new puppy, and boy, that must be kind of tough maybe with getting your sleep, or you so-and-so went off to college, and how you feeling about that, and connecting more, or saying, wow, I would have difficulty doing that. We got honest. Taking vitamins, I've heard, or just doing our exercise 5 times a week that we're recommended, we can't do. So connecting in that human way is important, and that allows for folks to maybe share more. And then the other piece was this open, or rather the bidirectional sharing, which is what we're just calling complementary expertise, meaning that there are 2 experts or maybe more in that room when you're in clinic or on the phone. And that's the clinicians who know their evidence-based guideline. They went to school. They have lots of great and professional knowledge that is key to driving the care for your children. And you too, though, you have knowledge that they don't know. You have a lived expertise, a lived experience that's important, again, to bring into that room, to that conversation. And it's the sharing, and that's what this kind of represents. This is an adult and a clinician in one of our sites we went out to visit, and they were talking about how she had just got a job. She had to move, travel further. How was she going to get her airway clearance in? And so they were talking together about, what are some options that are available? And so I wanted to ask you, again, do we need the mics? Oh, we have one, okay. Do you need help? Oh, you too, okay. I just was wondering if you would just join me for a moment of looking at shared humanity, thinking about what was, for those of you who are parents, what were you thinking or your child thinking when you were at the last clinic visit, or you were on your way in, or you're sitting in that room waiting for someone to come in? What was in your mind? We've heard different things that people have. Some people have, I got to get to the groceries. I got to go pick up so-and-so at 3. And it's a 1 o'clock appointment. You're not volunteer. Dr. Nazar has volunteered you.
Our last appointment was this morning, and I was actually at work, so I don't know what was going through my head. I mean, while I was at work, I was curious how I have 2 daughters, 11 and 8, both with CF. I was curious how they would do on their tests. We tend to be, in our opinion, pretty good at adherence, but there's always challenges with getting them to actually do their treatments, take their enzymes at school, etc. So I was just kind of curious how, how their numbers would be and how that went.
Yeah. Those numbers, those are really important, really important. They weigh heavy on people's minds. We are hearing that again across the nation. There's a lot of anxiety sometimes about what will that be.
Right, and for us, where that leads, are we looking at a possible admittance?
Yeah.
Or, do we get sent home this time for, did we eke it out a little bit longer?
Yeah, thank you.
I guess I got the mic.
Thank
Let's
you.
see, my
You guys are
guy's 12, going to be 13, and he's pretty stable. He hasn't been hospitalized since he was 11 years old. So he's doing fairly well. So I don't have a lot of anxiety going into clinic and a lot of vitamin D questions. And I'm not shy. I have a great rapport with my team, Valentino's team, that is. I think before going into clinic, you just have to organize every single spectrum of your day, whether it be school, pickup, food, snacks, traffic. You got to make sure there's gas in the car. I mean, everything in order to get to clinic, make a successful clinic journey, and then get back home and do homework, missed work at school. You have to have your checklist of all the questions you have to ask, and just make sure that you're thorough.
So organizing, and lots that you're
I think
organizing
organization is
to
key
get there, yeah.
to being a successful, adherent patient and a mom.
Great,
So,
thank you.
that's- Yeah,
Thank
thanks.
you. What about care team? Would you share a little bit about what maybe goes through your mind as you're getting ready to go in the clinic room? Oh,
Hi. I'm Kate. I'm a PT, and often we go in last. So I really feel for you guys because sometimes your faces are just like, oh my God. It's just, you know, in PT school, they described it as like trying to put your mouth over a fire hydrant when it's going on. You're getting all this information, and every person is saying, my part, it's the most important. And then you're like, I'm late. We're supposed to eat dinner, you know, half an hour ago. Didn't you say eating and calories were important? So I just really feel for you guys. And so we recognize that. And so be honest with us and kind of say, hey, today isn't going to work. Or if come in with a question and we can just review that. I feel like that.
Yeah. Thank you so much. That is a recognition there that the care team knows you've been sitting there for a while, and as Kate comes in at the last, she gets the. It's great though that she's seeing that, right? She's connecting with you and understanding you as humans. How about for complementary expertise? When we think about this, what is something unique that you bring, maybe, or your child brings that that you share about how CF is affecting you or your child? Is there anything that you specifically have?
So my daughter is making that transition. So she's 20, she'll be 21. So it's like a transition time for all of us. So me letting go, having her go to the appointments by herself, her organizing everything. And what I get back from her is, I get a lot of stuff back from her, but the you know what, you feel my pain. But she, you know, it's like like that whole trying to balance the whole thing. She wants to be 20. She wants to do what 20-year-olds do. She's a student here at U of M. She wants to be 20. She wants to pull an all-nighter and then still go out the next day. And, you know, oh, by the way, did you happen to do those 20 other things you're supposed to do during the day? So we kind of struggled through that for a little bit, but, you know, she has good days and bad days, and she's kind of made it around the corner where, like, she's owning things a little bit more. And so that's a good thing. I know that her, when she talks to me about it, because she'll tell me, I want you to come with me today because I know they're going to tell me X, Y, because she knows her own body. I mean, she knows. She goes, she knows when she's, you know, tanking out. She knows so she knows what she's going to hear. And so, you know, it's, those are the things that she shares with me. And then you know, and so that's when she wants me to come with her. I think she wants me to say, okay, she don't have to go in the hospital. It's like, well, I'm not going to say that, you know. Yeah. So it's like that whole transition thing, and it's just, I think one of the challenges, because as they get older, it's not like they're taking treatments away. Like you just seem to, you get another one, like the impact factor, like you said, it's not taking the place of anything. It's an addition to what you already do. So I think and then as an adult, when she goes to college, things are not getting easier. So it's like all of it all at once. Yeah. And I know me as a parent, you know, when she was younger, they always talked about these transition years and good compliancy at this time, and you know, so we were always kind of trying to make that on the compliance train all the time. And then she goes off to college, and it's just as hard because it's your things in life there's more things in life you have to do. And these things related to your disease process, there's always more things to do. Right. So, you know, I don't know how you solve it, or I don't know how you know, I don't know what the answer is, but you know, those are the things that she shares with me, and you know, it's just, and as a parent, letting go of those reins, and just, you know, and I try not to ask her about it anymore because, you know, she doesn't let me call on her at college, you know, because I ask her enough things. You have to go to class today. You did.
Yeah, there you go. Well,
So,
thank you.
you know.
It sounds like though she knows her body, and she probably looks to you for support. And to me, I think I would say that it's helping her have those conversations with Dr. Simon and Dr. Simon's team. If she's already switched, if she's not with you, she's still with Dr. Nazar. So having those conversations, because that's exactly right. She's in that stage of transition, and there's lots of ups and downs, and if they don't know, then they can't help her. Maybe readjust, see new ways of doing something. Sometimes it's timing in that. So it's bringing that complementary expertise, though, from her, is knowing her body and being able to share that, what's happening with the folks in the care team. So let me move on just to some of the ways that the partner, so again, I think that most folks are partnering. I think, again, this has come about because we just maybe haven't been as intentional at looking at it. And when we, again, have gone through the community asking various folks, we come up with 5 themes, and that advisory group that you saw earlier, the group still meets. It's a little bit different. They're actually now called champions, and they're out sort of doing this kind of thing, talking about it, working with their teams, and they're include parents, happy to have anyone who wants to work on with us, and we have adults, and we have lots of different clinicians who are going out, again, kind of just breaking open these conversations so that, and I don't know your daughter's name, but you know, that she doesn't feel alone and that she can't share, that she can share, and that there are ways to work out how to have a life and how to have treatments in CF. And so on your table, we had several different handouts that, you know, maybe it would be helpful for you, but they've come up with 5 ways to partner, which is just kind of condensed. What's on your sheets here might be a little bit different. We have 2 versions. We have one that would be more for helping you have a conversation with your care team, but we also have care team a version for you as well. And these really are dealing with creating I think they're kind of basic, but they're good reminders for us on opportunities that we have, because both people, where I was kind of going that complementary expertise, is both people are busy. The care teams are very busy too, and I know you recognize that they have lots of folks that they're running around trying to get time in to see whether it's inpatient, outpatient, and other duties. And so sometimes these relationships might sometimes recede to the background, and we want to pull them to the foreground. So creating a space for open and honest sharing, I'm going to actually go on. Yeah, did I do it? There we go. So what this really looks like, again, is sharing what matters to you so your team knows. Again, it may be I'm finding trouble to fit in enough meals during the day. Can you help me figure it out? Again, I'm sorry to go back to your daughter, but it was a really good example. She's having a tough time fitting in treatments. She's going to college or whatever the particular situation is. Can you help me with that? Can you help me think about how am I going to do all this and go do field hockey or whatever the sport or whatever the activity is? And the care teams reminding, just asking those open-ended questions can sometimes really set that tone of inviting people to really kind of share. So what's your schedule? And a couple tools I've given you came from other parents and adults with CF that may be helpful. One is a CF schedule. It's double-sided. You may find time in your life that you think that that's useful to map out, or your child may map it out with you. You can make copies. This is a CF map on your table, and the opposite side you can map out your own, and maybe your child maps out what's really important to you in life and what's important, and how do you get that CF care in as well. The second is understanding, I think, more than CF, right? Your child, or those of you who have CF, your people first. The CF is the second. And so it's, again, I think we were just mentioning some things about life pops up, new things happen, you got to make adjustments. Again, how do I fit that all in? How do I balance? This is just a quote of saying, we just started a new school last week, so we're trying to get back into a routine. We did come off, a few things because of the summer. And the care team, I think learning about making intentional efforts to learn about what else is going on and maybe can lead to some new recommendations. So changing schools is tough. Is there anything we can kind of do as you go through this transition? Communicating between visits. This may seem like you already do it, but perhaps, again, there's this more intentional to make sure that folks do know. They can, I don't know, whatever your system is. Maybe you have CF MyChart. I don't know if you use Epic or what you use. Or perhaps use emails, or perhaps use phone calls. Every clinic is different. So managing CF, why wait until the next time you see a clinic visit? It could be 3 months, maybe 2 months, maybe even shorter, but maybe even longer. So the care team wants to hear from you. I'm not sure my nasal rinse is working. How do I know if I'm doing it right? That's a question. And inviting folks to contact you. Again, these are things I think that probably are just every day, but it's making, maybe I could say that more in clinic, so that learn how, call me in 2 weeks, or I'll call you. What's the best way for us to contact one another after we have this conversation? Here's another one, inviting input from others. Oftentimes people have said to us that sometimes if their spouse or their parent know something, or maybe they pick up on something that I didn't. There's a new cough. Oh, I heard, you're having trouble sleeping last night or the last few nights. Is something new going on that you, as the person with CF, may not always recognize it, or your children may not. Oftentimes they do, but if not, there's always an option to invite other people to share. We did have one adult share with us that she was about a diabetes, CFRD, and she was saying, oh, people told me to not have the orange juice because, I have diabetes. And so they were saying that, but that's not really what my particular issue is. That's not how I should just take that away. So they were talking about how could they talk to that person about how, what she needs versus maybe what their perception was. And then the last is really approaching the difficult conversations with respect and an open mind, because sometimes, and this is uncomfortable, sometimes we don't agree. And that's just in human nature, that sometimes we don't always agree on a course of action, but we still need to have those conversations. And I think we can have those conversations, but we have to be sharing it in a respectful way, and perhaps also in an open mind. There isn't always a right way, and some folks might feel like maybe they do want to try something that's a little bit more healthier option, but how do we work together to try your healthier option? Perhaps it's for a certain period of time, and then if it's not working, there's a goal you set, then you bring in the other option. And so how do you really work together to look at the recommendations that are in guidelines or in research, but also bringing together lived experience or your lives? And so, Erin, I asked two parents if they would start us off with just sharing some stories, and then I wanted to kind of open it up. I don't know, how are we doing on time? Are we okay? Okay. So Erin could not be with us, but we had a chance to talk to her, and then where's Wendy? Oh, there you are. Okay, we'll be right with you in a second. And this was just to illustrate, again, these partnerships that you have here in Michigan and how it's working. And we've found that sometimes when folks hear these, they might not want to volunteer their own story, but sometimes it's helped validate a little bit or encourage them to have a conversation that's different next time that they come to clinic or together. And I'm sorry for ignoring the side of the room. I apologize. So Erin shares with us that for the things they've experienced, the clinic has been quick to address her concerns. They're always answering questions and giving us tips and tricks. They are covering all bases. And her particular situation here is with her daughter, who's about 5. She says the care team knows that her daughter really has a hard time with the vest that they provide, and they've provided a lot of resources to encourage her. And as she says a little bit in a different, in the other version of the story that I have at home, it's like, it's really hard. It's like a double whammy. I have a young child who has CF, and she doesn't want to do her vest. This is really a stressful point for us. How do we do this and get her to do it every single day? And so the team has been working with her, and I don't know, Kate, if it's yourself or the physical therapist. Oh, okay. There you go. Has been working with her to have this more positive, lifelong relationship with this treatment. And so I'm not quite sure what you're doing, but it sounds like it's really working really well. And I like the lifelong relationship with this treatment. I think that's a really nice way of framing it. So there's also the addition of the physical therapist, and as a mother with a young child with CF, it's really great to hear about things I maybe haven't experienced yet, because I like to be prepared and have a sense of what's to come. So you've obviously spoken with Mom. You have an understanding that she's proactive, and it's really helpful to decrease stress by being proactive. I love having the physical therapist come in, prepare my daughter for things older life, like the huff cough, fogging up the mirror, or blowing the bubbles. There's a space to ask questions and get a clearer picture painted of what may be coming down the line. And I never feel like I have more questions than I came with. So I think to me that illustrates that you guys really had a nice open conversation. You could anticipate some of the information that would help this family. Not all families perhaps want to be thinking about things in advance, but for this mom and her child, this is really helping, again, because it's a stressful time when her child doesn't want to do vest therapy. And Wendy, I apologize. Wendy is going to share a story with us, and I think she wanted to thank you, Wendy, for offering your story, a partnership.
So mine has to do with when my son started high school. And I'm always trying as a parent to do everything that the well, I try to do it. I don't know how well he does, but I'm always trying to do what they say. And so when he started high school, he had to leave the house by 5:45. And so I don't even know that I asked the question or if it just came out with how are things going or what, but I said it's so hard to get him up and have him nebulized before he leaves for school at 5:45, because you can barely drag him out of bed and get him ready, and eat something and get him out the door. So, I mean, it was just like, well, he can just do it after school. And I'm like, oh, it was like, so after fighting with him for I don't know how long, we just switched it. Now he nebulizes after school and then he nebulizes before bed. So it was as easy as that. So you just have to make sure you bring up all of the things that maybe aren't working, even if you think there isn't a solution, because you might be pleasantly surprised that there is. So we were happy to have that.
Thank you, Wendy. So they created a space that's sort of that open space, and you could share openly and find out a solution that actually was a little bit simpler.
Yes, much.
Than might not have thought about. So, and the care team was open to having that conversation. Partnering isn't easy, and I don't want to leave on a negative note, but I just wanted to recognize that it's not always easy, and some of you have shared some stories a little bit touching on when it's not so easy, and I think it can feel uncomfortable. And there's, multiple reasons. This was just a top few. Partnerships are very dynamic, they're fluid. It depends on the health status as well. So sometimes they might be really working well and sometimes not. Maybe I'm just not feeling well. Some of our adults may not be really active in a partnership with you, but then all of a sudden not feeling well. And so, it was just with actually 2 parents last weekend who did the actual presentation, and I was just sort of facilitating, and what they talked about was the dance. And now I'm not a dancer, so I won't get into the nitty-gritties of dancing, but the idea of the leading, and sometimes somebody leads and somebody else might want to lead, and trying not to step on each other's toes. And I thought that was just a really interesting analogy to kind of think about when you think about partnering. We just mentioned before some individual dispositions. All of us have different personalities. Some work, some don't always. But the nice thing about having a clinical care team that has multiple people is there's lots of different people you can partner with. Sometimes we don't have the skills. Sometimes we don't have the capacity. Maybe some things in our lives are really kind of hindering us from being able to be as active as we want to. Because when you're worried about where the next meal is, or if there's even a meal, that can really kind of derail what you're thinking about. The interest, and then there is this healthcare dynamic, right? There is this power distribution that we have to recognize. I think it's physicians and nurses and respiratory therapists and medical professions. There is this sense of inherent power just being in that medical profession that we don't, whether any of us, are patients and families, even when we're our own patients, and all of us are patients at some time. There is this slight difference that we should recognize, because it could make it difficult to say something. Internal and external pressures, I think we've heard a little bit about some of those pressures that kind of maybe come up if the numbers are really making us feel very disappointed despite what we're doing. External pressures when the hospital is setting up times for Dr. Nazar and the team to see you within 20 minutes, 30 minutes, 50 minutes. And then there are cultural differences. In some cultures, the idea of speaking with a medical professional is not seen as something that's something that you should be doing. And so there's a lot to take into account when we're trying to get the best health and wellness for your child or yourself. And so, but I think that we do know that they are built over time, and they are built on this foundation of caring, and they do, I think, at the end of the day, are the most valuable that we have for best health. And so moving forward, again, I started us out with some reflections. I still think these hold true to reflect on. Perhaps, again, have your child sometimes, what would help you partner with your team? What would help you say something to your team? And then moving forward, you might think about, so what does this look like at your center? What are ways you might make tiny improvements in strengthening and deepening it? And what opportunities do you have? I did, again, give you some tools. We do have tools on our I think, cff.org as well. We have those 5 ways to partner, the CF map. You can come up with a bunch of different tools, but they're tools to help you have those conversations. And they're all for the fact, right, for journey. It's a journey in partnering in CF with the ups and downs. And it's all for your children and all of these wonderful faces here to lead those long and productive lives that we all are striving for. So thank you very much for your time. I very much appreciate being with you here.
We wanted to give you something to remind you of your
Oh, my
trip to Ann Arbor.
gosh.
This
Oh,
is,
wow.
Dale Fisher is one of the photographers that specialized in taking pictures of Ann Arbor. I actually, yeah.
Y'all see?
Right.
Everybody's gonna want this.
Right. And then,
Oh, that's special.
and
Thank
then we're
you.
known for Zingerman, so that's just a little bit of a gift card for Zingerman. It's a restaurant that Ann Arbor is known for.
So I gotta come back.
Yes.
All right.
Yeah, but you can order too. And this is for Sarah because we love having you here with us. So
Thank
it's
you
just
very
a
much.
small
Thank you
thing
very
for
much.
Right. No problem.
you.
Always have a picture.
Oh, we have a group picture, okay. She's very kind. Oh, here, you get in the middle. We love her. We love her when she comes visits us. Oh, hey, I should show you.
I know, right? And maybe Dr. Simon can come over.
Oh, yeah, where's Dr. So get up here, Dr.
Yes, come on.
Come on, Dr.
You're-
Simon.
He doesn't like to take pictures. We'll
Oh.
cycle the old pictures.
Okay. Okay, would you like that? Okay, there we go. Thank you so much.
Okay.
Thank you. Thank you so much. It was just so lovely to meet you.
Thank you. Yeah, right. You've got a lot of travel. I appreciate you.
If there is any questions, you can either track
Let
us
you guys
down.
talk.
Evaluation is very important, so I did not forget that. So please fill your evaluation. Tell us what topics you want us to cover. If you want anything specific, we'll be happy to accommodate that. So thank you very much.